Great. Well, good morning, everyone. My name's Kelly Boprie. I am an outpatient therapist for GR Therapy Group, and I'm excited to be here today. Before we get started, can I just hear a little bit of like who's here? Are you guys mostly school counselors? Do some of you work for agencies? I would just love to just have a little information about the audience of who's here today.
I've just given everyone permission to unmute themselves.
Okay.
So you can.
Okay, so a lot of school counselors. Okay. Mostly high school counselors, it looks like. Well, great. Well, today I'm hoping to cover a couple of different things to really give you guys a good overview of the typical eating disorders that exist, looking at some statistics, looking at contributing factors to the development and maintenance of an eating disorder, some assessment and medical aspects of eating disorders, and then some treatment of eating disorders with a specific focus on what's called FBT, family-based therapy, which is really kind of the standard, it's the standard care for anorexic youth who are refeeding in the home. So it's really a helpful therapy for teens who are still living at home and parents are focusing on the weight restoration instead of sending a kid off to res or inpatient. Because unfortunately in Michigan, we don't have any residential treatment centers for eating disorders. We don't have any, we have Forest View, but we don't have any places like Toledo Center or Eating Recovery Center, places that can do residential. So I hope to cover all of those things today and then to leave some time for questions at the end. So let's get into it. I'm just gonna move my screen over here a little bit. Okay. So eating disorders affect people of all ages and genders. However, adolescents are particularly vulnerable to the development of an eating disorder. In my practice, I do see both teens and adults, and I'm seeing a big uptick recently in the development of eating disorders, specifically since COVID started. I'm seeing a lot of teens who started to develop an eating disorder during quarantine, when there was that time where people weren't able to leave the home, where there was more time to focus on, weight loss, food, exercise. So I'm seeing a big increase lately in teens who have developed an ED. Eating disorders are the third most common illness in adolescent females, with only diabetes and asthma being 1 and 2, which that's pretty telling that this is the third most common illness. Whether it's anorexia, bulimia, ARFID, binge eating disorder, a lot of our teens are struggling with an eating disorder. The average age of onset of eating disorders is between the ages of 16 and 18. But again, in my practice, I'm seeing a lot of 13-year-olds right now, 13-year-olds who really do actually meet the criteria for anorexia. Eating disorders occur in nearly 3% of 13 to 18-year-old teens. So really that's a pretty big population in our schools, 3% of teens between the ages of 13 and 18. And those are really just the known diagnosed ones. When researchers followed a group of 496 adolescent girls for 8 years until they were 20, they found that 5.2% of the girls met criteria for DSM-5, anorexia, bulimia, or BED. And when the researchers included non-specific eating disorder symptoms, a total of 13.2% of the girls had suffered from DSM-5 eating disorder by age 20. So some of those non-specific eating disorders could be more of like a lot of issues with body dysmorphia, not meeting full criteria for anorexia, bulimia, ARFID, or binge eating disorder, but meeting criteria for like more of the other specified eating disorders. There might be some restriction going on, might be a couple cycles of binge purge behaviors, but not enough to meet the full criteria. I need to move this really quickly, sorry. 62.3% of teenage girls and 28.8% of teenage boys report trying to lose weight. 58.6% of girls and 28.2% of boys are actively dieting. 68.4% of girls and 51% of boys exercise with the goal of losing weight or to avoid gaining weight. So exercise has not become something that's joyful for them. It's not been something that they want to do to move their body to just move their body. It's for the purpose of changing the aesthetics of their body. It's for the purpose of compensating for food. It's out of fear of gaining weight. So we're seeing a big change, and what was once enjoyable fun in a way to manage stress has now become something compulsive, something that's needed in order to lose weight, to earn their meals. Even among clearly non-overweight girls, over 1/3 report dieting, which is a lot. That's a lot of our high school students and middle school students who are trying dieting, on a diet, or have been dieting. In a poll of adolescents cited by the National Eating Disorder Association, researchers found that 33% of males used unhealthy behaviors to control weight. These boys may have used exercise, diet changes, or both in order to drop pounds and make their bodies slimmer. So with males, we're seeing a lot of males who are at the gym a lot, doing a lot of work around changing the aesthetics of how their body looks, with developing more muscle mass, and really cutting food, using replacements like protein shakes instead of actual meals, just in efforts to change the aesthetics of their bodies. This is a scary statistic when I think about it. Like, eating disorders have the second highest mortality rate of all mental health disorders, only surpassed by opioid addiction. And we know how vast opioid addiction has become in the last several years, and eating disorders are right behind them. And anorexia has an estimated mortality rate of around 10%. I'm trying to move to the next slide and it's not letting me. Okay, there we go. So contributing factors to eating disorders. Actually, that was not my next slide. Okay, sorry about that. So I wanted to give a moment to recognize Black, Indigenous people of color and the LGBTQ community, because these are communities that are often misdiagnosed or missed. So BIPOC are significantly less likely than white people to have been asked by a doctor about eating disorder symptoms. And that's pretty telling, that we're missing this population, that and in physicians' offices, that they're not getting screened as often or as assessed. Same with the Hispanic population. That's pretty true for them too. BIPOC with eating disorders are half as likely to not be diagnosed or receive treatment. So this is a big gap. These are people who aren't having access to treatment because they're not being assessed, they're not being inquired, doctors aren't inquiring about symptoms that they might be experiencing, and even sometimes outpatient therapists might not be. Black teenagers are 50% more likely than white teenagers to exhibit bulimic behavior, such as binge eating and purging. Hispanic people are significantly more likely to suffer from bulimia nervosa than their non-Hispanic peers. And more than half of lesbian, gay, bisexual, transgender, and queer young people between the ages of 13 and 24 have been diagnosed with an eating disorder at some point in their life, according to a new report by NEDA, Reasons Eating Disorder Center, and the Trevor Project. Gender dysphoria and body dissatisfaction in trans people is often cited as a key link to eating disorders, just difficulties with their bodies and the changes in their bodies, and not being connected to their bodies and wanting to change the aesthetics of how their bodies look. Non-binary people have more tendency to restrict their eating to appear thin, consistent with the common stereotypes of androgynous people in popular culture. And trans individuals experience eating disorders at rates significantly higher than cisgender individuals. So some contributing factors to eating disorders, especially for teens, is puberty. So there's obviously an increase in hormones during puberty, bringing significant physical, psychological, and emotional changes. Most visible are changes, obviously, to the body shape, how the body looks. Male adolescents typically gain more fat-free body mass during this time, while females gain more fat tissue. These changes in weight are both natural and healthy, but adolescents often feel uncomfortable in their rapidly changing bodies. So complaints about, hips widening for many of our teen girls, or noticing more weight gain in the breast area, and just the changes in the body that happens when a teen enters into puberty. Puberty involves an increased attention to the demands and expectations of the dominant culture, peer influence, absorbing external messages that girls need to be in control of their weight and maintain an attractive body. So a lot of those sociocultural influences really hit on the teen girls during this time. Genetics, there's a strong genetic link to eating disorders. So an estimated heritability of 50%. So examining family history for obesity, anorexia, and other eating disorders is important. Genetic tendency appears to be activated at puberty, around that age 12, 13. Girls who feel more negatively about the changes that their bodies go through during puberty are more at risk. Serotonin and norepinephrine are decreased in acutely ill individuals with anorexia and bulimia, representing a link between depression and eating disorders. And women with a mother or sister who has had a diagnosis of anorexia are 12 times more likely than others to develop themselves. And they're 4 times more likely to develop bulimia. So we do see a strong genetic and hereditary component to the development of an ED. Moving on to some other factors, we do know socioculturally that teens are very impressionable, and just the influence of social media and technology. And research has shown a correlation between teens' social media habits and disordered eating and body image concerns. The focus on appearance and the use of social media to promote appearance seeking, as well as to tear down appearance by bullying and shaming on social media platforms as a factor. Diet culture and the use of diet culture to promote the thin ideal all across social media. You can see it on TikTok, on Instagram. We've moved kind of away from some of the thinspo, inspiration, and we've moved into this fitspiration with different, Instagram influencers who are posting their tips, their techniques, their ways to change how their bodies look, the aesthetics of their body through these diet and workout programs. And teens are really impressionable. And if you spend a lot of time on TikTok, which a lot of our teens do, there's a lot of dangerous stuff out there, ways to cut calories, ways to restrict. There's pro-Ana stuff out there that just is really dangerous for a lot of our teens, again, who are so impressionable. And if you just go on some of the videos and you look at the comment section, teens who are being praised for not eating for 3 or 4 days, teens who are being praised for eating vegetables instead of carbs, which our brain and our body needs. So yeah, there's just that growing trend right now of, unfortunately, pro-Ana and peer support that's found on TikTok, which is just really dangerous for our teens. And growing up in tremendously body conscious households, for example, if the mother or father is constantly dieting, exercising, commenting about weight issues, whether it's their own weight issues, the weight issues of the child might begin to emulate the parent's behavior just as a way of trying to find some acceptance. So moms that might be chronic dieters, or dads who don't take breaks from their running and workout programs, it's very impressionable. Our teens are paying attention. They're aware of what their parents are modeling. So it's something to be aware of. Psychosocial and emotional concerns, certain personality traits and mental health diagnosis are risk factors for the development of eating disorders, including perfectionism, body dysmorphia, OCD, anxiety and depression. Perfectionistic tendencies, really rigid thinking patterns, kind of that black or white, all or nothing thinking. Difficulties with flexibility, and difficulties with feelings or loss of control can be contributing factors. And with the pandemic this last year and teens being asked to leave school, really being forced to leave school and having to come back home, there was a big loss of control, not being able to see their peers, not being able to hang out, participate in their sports, their music, their group, their clubs. That's had a big impact on them, and a definite contributor to the development of eating disorders, depression, and anxiety. And eating disorder behaviors can oftentimes offer a way to manage negative feelings through avoiding. So if I don't eat and I focus on not eating, I can numb, I can dull a lot of those emotional feelings that might be heavy, anxiety, fear, depression. So some individuals may begin to self-soothe by the rigid controlling of their diet, as it becomes a way, again, to feel power and control over their daily lives instead of feeling like helpless. We know that trauma can be a precursor as well as issues with attachment. So the way that they attached as a child, the way that they've attached as a teenager, that can be a factor as well. And then environmental, I've already talked a little bit about this, but how food's presented and discussed in the home. Is this a home that um, is dieting or is making more of an effort to clean eat, so there isn't access to foods that the teen wants to have, like chocolate or cookies. So how food is discussed in the home has a big impact too. Are these bad foods or treat foods, or foods that we can only have on special occasions? Or are we creating an environment and culture at home where all foods fit? So when we're moralizing foods as good or bad, um, or if we're talking about meals being cheat meals, that's going to have an effect on somebody who already might be predisposed to developing an eating disorder because it's sending a message. So we want to be cognizant of how we're talking about food, the access that teens have towards food. One of my teens this week, we were able to meet with mom and we're able to talk about the need to buy the foods that mom was scared to buy, like candy, chocolate chips, because not having them in the home was making it more and more difficult for my client because she was sneaking those foods because mom wasn't purchasing them. And as we normalize them, allow them to fit in the home, that child doesn't have to sneak, there isn't shame around it. And they're sent the message that, hey, all foods fit, we can have access to any and every food. So again, nutrition, how nutrition and body is discussed in the home. So if we again have a parent who's chronically dieting, it may send that message that weight gain's bad, that restricting can thus become normalized. Or parents that are on and off keto, on and off elimination diets, whether it's gluten or dairy free, it can send that message too to a child who's already predisposed, to a child who's already been on social media and who's already experienced some body dissatisfaction and some inaccurate messages about food and body. So again, we want to be cautious of how food's presented and how we're talking about food and what we're modeling. So moving on to specific eating disorders that we're going to see with our high school students. Anorexia nervosa is one that we've all heard about. Anorexia nervosa is a psychological and possibly life-threatening eating disorder defined by an extremely low body weight relative to stature. This is called the BMI, which we're familiar with. And this is a function of an individual's height and weight. So with anorexia, we're going to see an extreme and needless weight loss leading to maintenance of a body weight less than 85% of that expected, or failure to make expected weight gain during a period of growth, leading to body weight less than 85% of what's expected for their body. So there's also the logical fear of weight gain, very, very scared about gaining weight despite being very, very thin, or not even always very thin, which we'll talk about, but a logical fear of weight gain because they're scared of their body changing. And there's this distorted perception of self-image and body. So to be diagnosed according to DSM-5 with anorexia, the criteria is there has to be restriction of energy intake relative to requirements, leading to a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. So restriction, not getting enough nutrition, the body's become malnourished, the body's not getting enough energy. So there's also the intense fear of gaining weight or becoming fat, even though they already are very underweight for the most part. Unless they have a atypical anorexia, which we'll talk about. And then there's a disturbance in the way in which one's body weight or shape is experienced. So undue influence of body weight or shape on self-evaluation, or the denial of the seriousness of the current low body weight, which I often see as this idea of I'm not sick enough. Like, look at my peers, they're thinner than me. They don't oftentimes are in that state of denial and they don't recognize how sick they actually are because, again, their brain is starved. So cognitively, they're not able to actually recognize how sick they actually are. And as the brain continues to get starved, more and more starved, they oftentimes have a lot of difficulties with flexible thinking, being able to see the big picture. They're there, but their eating disorder has now become the lens that they're viewing self and world through. So that's why we also see that intense fear of gaining weight, because the eating disorder has really hijacked their perception. So there are two types of anorexia. We have the binge purge type and then the restrictive anorexia. So the binge purge type, this is when an individual is actually engaging in binge and purge behavior. So this is typically the result of them feeling overwhelmed. So they might be feeling feelings of guilt, specifically guilt or anxiety related to eating, and because of the guilt and anxiety that they had around the meal that they just had, the snack that they had, they may engage in actually purging behaviors of throwing up their food by vomiting, or they might use excessive exercise, exercising for hours in efforts to try to purge themselves of the food that they just ate, as well as abusing laxatives, sometimes diuretics, doing whatever they can to purge their body of that food. Restrictive anorexia, this is a form where the individual will fiercely limit the quantity of food consumed, characteristically ingesting a very minimal amount that is well below their body's caloric needs, effectively slowly starving him or herself. They're rarely eating, maybe eating under 500 calories a day. Some of them aren't even eating that. And oftentimes with the restrictive anorexia, they are eating foods that are very, very low in calories, a lot of vegetables, a lot of foods that, again, have very little caloric value. So though two classifications of anorexia nervosa exist, both types exhibit similar symptoms such as that irrational fear of weight gain and abnormal eating patterns again. So it's so important to know that these individuals have that irrational fear of gaining weight, that their body's going to change, that they're going to become overweight, and they have a hard time recognizing that they are actually unhealthy or even underweight. So atypical anorexia, we don't talk about this enough, but you don't have to be overly thin to have anorexia. So contrary to many of the stigmas assumed about anorexia, a person can present with the restrictive behaviors and features of anorexia, such as that fear of gaining weight, low restrictive diet, difficulties recognizing how thin or how frail they might be. That's typical in the main anorexia, but atypical, they might not be thin and frail, but they also have the fear of gaining weight. They've cut calories, the restrictive behaviors, some of the compensatory behaviors if they're the binge purge subtype, but they don't meet that low weight criteria. So these individuals oftentimes get missed. So they might present with a normal weight range, and sometimes they even present as overweight, and they're not identified again as anorexic because of their presentation is atypical. They don't look thin and frail, but what's going on inside their body is so common to what's going inside of the body of an anorexic who might be very frail and thin. They might be having bradycardia. They might be having the slow GI tract with slow gastric. Their digestive system is slowing. They also might be presenting with the low body temperature, but because of the aesthetics of their body doesn't look thin and frail, they aren't always assessed for anorexia. And again, someone with atypical anorexia can be terrified of weight gain and becoming fat, and they may display specific disordered eating behaviors, including restricting food groups, calorie counting, as well as avoiding functions and events involving food. So not going to team dinners because they don't want to eat, not eating lunch at the school cafeteria table, because that's another way that they can restrict. But again, their body doesn't look frail or thin. But again, all the medical complications seen in anorexia are seen in equal frequency with atypical, despite that significant weight loss. So these individuals are still experiencing that biology of deprivation, where there's that malnutrition, they're getting insufficient energy intake, but again, might be because of genetics that their body hasn't changed, might be again because of like the body going into that state of starvation, so they're holding on to fat and trying to reserve their fat so that the aesthetics of their body doesn't start to change on the outside, but again, a lot of the same things are happening on the inside. So some signs and indicators of anorexia. Oftentimes this begins with an individual restricting foods. So they might start innocently with, oh, I'm just going to be more aware of what I'm eating, but now they're cutting out carbs, dairy, sugar, and the food intake is becoming increasingly limited. I always say that with anorexia, they're always looking to restrict. Anorexia is always finding ways to restrict. So maybe I stop putting butter on my, baked potato. Maybe I stop putting whipped cream on my latte from Starbucks. There's a fear of gaining weight, becoming fat is extremely intense. Rather than lessening as weight drops, this fear usually worsens, which is so true. As they continue to lose weight, that fear of gaining weight worsens. They might make frequent comments about feeling fat, even despite weight loss, preoccupation with food. So a lot of my teens actually were cooking a lot of the meals in the home, and it started off as something innocent with exploration of food, and as their eating disorder started to take over, it was more this preoccupation. They would bake food, they would bake treats or make dinners, but they wouldn't participate in eating them. Guilt and anxiety and anger around food and meals, just getting really angry, working with one of my teens last night and observing the family meal, crying tears because dad put some butter on the baked potato. There's a decrease in appetite, which makes sense. They have starved themselves. They're experiencing malnutrition. So a lot of those body functions start to slow down. And one of the main body functions that slows down is being able to detect appetite. And because our body's going into conservation mode and reserving energy, we experience that decrease in appetite. They have changes in hormone levels in females, often resulting in the absence of a period. Specifically if the weight loss occurs before puberty or as puberty starts, and sexual development can be delayed, and some growth might cease. There, we might notice a development of lanugo, soft fine hair that can grow on the face and body because the body's cold, and the growth of that hair is a way for the body to try to conserve energy. Thinning of hair or hair loss, fatigue, low energy, which makes a lot of sense. Their body's starved, their food's energy, they're not getting enough energy. Chronic constipation, so that slow GI tract, they're going to complain of not being able to produce a bowel movement. They might dress in layers to hide weight loss, which is very common. Baggy clothes, and I know baggy clothes are back in style right now, so that can be hard. They might be drinking water excessively, non-caloric beverages like your bubblies, LaCroix, diet sodas, dizziness, lightheadedness, and faint, because again, they're not getting enough nutrition, stomach cramps, as well as bradycardia, because their heart rate is slowed down to try to conserve energy as well. I'm not going to do this slide because it's already 9:42, but it just talks a little bit more about some of the ways anorexia affects your whole body. The course of anorexia, it again begins more during adolescence, before the age of 17. The onset is often related to a major stressor or change. Could be divorce in a family, a breakup, abuse, going away to college, that big life transition and moving out of being in the parents' home and moving into independence. Again, I've seen a lot since COVID started because that was a major life stressor. The course and outcome are highly variable. Some recover after a single episode, some don't recover until 4, 5, 6 episodes of treatment. However, the best course of recovery, the best outcome for recovery is when they get into treatment as early and as soon as possible. And there can be a fluctuation pattern of weight gain followed by relapse. So a teen might go into treatment and they might go inpatient or res and they get weight restored, but they come home and they lose that weight again. And then we're going back into another episode of the anorexia. And then chronic deterioration course of the illness over many years can result in death. So if they constantly can't battle this anorexia, if they can't get to a place in their recovery, it can result in death due to starvation and all the medical complications that can come with anorexia. So bulimia, this is a serious, potentially life-threatening eating disorder characterized by a cycle of binging and compensatory behavior such as self-induced vomiting designed to undo or compensate for the effects of binge eating. According to the DSM, the official diagnostic criteria for bulimia, involves recurrent episodes of binge eating. So an episode of binge eating is characterized by both of the following. So eating in a discrete amount of time within any 2-hour period, which an amount of food that is definitely larger than what most people would eat during a similar period of time and under similar circumstances. And then there has to be a sense of lack of control over your eating during the episode, a feeling that one cannot stop eating, or control what or how much one is eating. So that then we experience the recurrent inappropriate compensatory behaviors in order to prevent weight gain. So we might see the self-induced vomiting shortly after the meal, going to the bathroom, the misuse of laxatives, diuretics, excessive exercise to compensate, to try to purge them of the food, and even fasting, going on a cleanse, or I'm not going to eat for the next 3 days. The binge eating and inappropriate compensatory behaviors both occur on average at least once a week for 3 months. And again, with anorexia, self-evaluation is unduly influenced by body shape and weight, and the disturbance does not occur exclusively during episodes of anorexia nervosa. So for bulimia, there is the binge and purge cycles. So we have the purging type, which is self-induced vomiting and laxatives as a way to get rid of the extra calories. And then we have the non-purging type, where a person uses the fasting and excessive exercise to make up for the binge. One of my clients was exercising 3 to 4 hours a day in the evenings because that was her way of trying to purge her breakfast, lunch, and dinner. So understanding a binge, because there's a lot of confusion sometimes around this. Sometimes people think that they're binging where it's just a subjective binge and not a true objective binge, but a binge is defined as the rapid consumption of a large amount of high calorie food in a short amount of time. It's marked by a feeling of being out of control, where that person literally feels like they cannot stop themselves from eating. And even sometimes there's this dissociation where they're no longer aware of their eating, actual kind of out of body experience. The actual binge may or may not be planned. Sometimes it is planned. You know, their parents are out of the home and they know that after school from 3 to 4, mom's not home. That's my time to eat the foods that I don't typically get to eat, or the foods that I have shame around. So they might plan that out because they know mom or dad aren't going to be home right away. And they may consume 2,000 to 10,000 calories in a single day. They usually prefer the high calorie foods such as sweets, fast foods, high carbohydrate foods. The binge generally lasts until the individual is uncomfortably or painfully full, and it's often done in secret. Just an example of kind of the binge purge cycle. A teen might experience some feelings of anxiety. They don't like the discomfort of anxiety. Okay, it feels really uncomfortable. I don't know how to tolerate this feeling. I don't know what to do with this, because maybe that teen doesn't know how to manage their feelings or emotions. So they know food, hey, food's a way that I don't have to think about how I feel, you know, or they start to recognize food is a way I get that little dopamine hits, you know, I get that dopamine hit that like makes me feel a little bit better. So I turn to food, and now they're in this cycle of binging, overeating. And after the binge, there is this fear of gaining weight. There's this immense fear of their body changing. You know, eating all of that high calorie food is just sitting with them. They're perseverating on it. And that's when the purging starts, whether again, it's the compensatory behaviors of over exercising, or actually purging via vomiting. And they experience a loss of fear or a weight gain temporarily after the purge. It's almost like this release. Okay, I feel okay now. I can move on. I've gotten that out of my system. But unfortunately, then they're hit with feelings of guilt or shame later, like what I did was wrong. I feel really bad about what I did. Maybe there's this values discrepancy. I value health and wellness, but here I am throwing up or over exercising, and it's keeping me from my friends because I'm spending so much time with that. So then here enters the feelings of guilt and shame. And then we're back to feeling anxious, and we get stuck in this cycle. Some signs of bulimia: frequent episodes of consuming very large amounts of food, followed by behaviors to prevent weight gain, such as the vomiting, overexercising, laxative abuse, going to the bathroom immediately following a meal, discomfort eating around others. This is very common. I don't want to eat lunch around my peers. I don't want to eat around my parents. I don't want to eat around my siblings. Disappearance of food or hoarding food because they're eating in secret. They don't want people to know. So you might find wrappers in their bedroom, or wrappers in their trash. Restriction, because again, a lot of times they're practicing that restriction of, I'm not going to eat for hours or days because I think that's a way for me to lose weight. But that restriction sets them up for a binge. Dehydration and weakness because of the purging. So their electrolytes are off, their potassium is off, their phosphorus, their sodium in their labs. feeling out of control during the binge eating episodes, dental issues, discoloration of teeth, swelling of gums, bleeding gums because of the acid from the purging, the constant acid on the back of their teeth, and then them not brushing their teeth because of it. Creation of a schedule and rituals to make time for binge and purge sessions. Again, they're rigid, so they like their schedule. And if there is disruption in it, there's disruption possibly in their ability to get to their purging behaviors. Self-esteem is overly related to body image. There's obsession with weight and fear of weight gain. The course of bulimia may be chronic or intermittent and often presenting for several years, especially if not in treatment. And there's periods of remission can occur, especially during pregnancy and post-surgery. But again, early treatment has the best outcomes. So moving on to BED, binge eating disorder, the key diagnostic features of BED, according to DSM, are recurrent persistent episodes of binge eating. Binge eating episodes are associated with 3 or more of the following: eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because of being embarrassed by how much one is eating, feeling disgusted with oneself, depressed, or very guilty after overeating. So we're going to see individuals who are eating a lot of food and they're uncomfortably full. We're going to probably see some abdominal distension because of that. They're eating quickly. A lot of times they're eating quickly too because they're eating in secret and they don't want to be found out. They don't know how much time they have. There's that loss of control. And again, they're oftentimes not hungry. Binge eating can oftentimes be something that a person uses to self-soothe, to deal with feelings of lonely, disconnect from others, boredom, restlessness. So that's why a lot of times it happens when they're not physically hungry, because it's a way to self-soothe. Marked distress regarding binge eating. They do feel very stressed, overwhelmed, and feeling shameful after a binge. Binge occurs at least once a week for 3 months, and there is no compensatory behavior such as purging, over exercising, laxative abuse. So that's the key distinguisher from bulimia, that they are not using compensatory behaviors. Negative affect is most commonly the precursor to a binge episode. So whether it's anxiety, depression, feeling restless, bored, lonely, it also can be triggered by interpersonal stressors, conflict with a partner, boyfriend, girlfriend, family stress, stuff that's going on in the home. Maybe parents are going through a divorce, grief or a loss, feeling bad about body weight, shape, and food, dietary restraint too. Again, if you are starving your body, if you're not feeding your body on regular intervals on a schedule, you are setting yourself up for overeating and even binge eating, because the body is not designed to go these long periods of time without eating. So at that point, if a person has actually been in a state of starvation and restraint, it's not even a loss of self-control at that point. It's the body's biology of deprivation, recognizing I'm malnourished, I haven't gotten enough nutrition, there's food in front of me, my blood glucose levels have dropped, I'm going to eat, and I'm going to eat a lot because I don't know when I'm going to get fed again. So ARFID, this might be something that people aren't as familiar with. It's a new diagnosis that came out with the DSM-5, and ARFID is an eating or feeding disturbance where there's apparent lack of interest in eating food. There's avoidance based on the sensory characteristics of food. There's concern about aversive consequences of eating as manifested by persistent failure to meet appropriate nutritional or energy needs associated with one or more of the following. So with ARFID, there's oftentimes significant weight loss, failure to achieve expected weight gain, or faltering growth in children. A lot of times these kids are way off their growth chart. They're very undernourished. So they're very low on their weight and height growth chart. So there's significant nutrition deficiency because of the restriction and their loss of interest in foods. There's dependence for some on maternal feeding or oral nutritional supplements. Some of them might have NG tubes because they're not eating. And they're supplementing with different supplements, whether it's Ensure or Boost. There's marked interference with psychosocial functioning. The disturbance is not better explained by lack of available food or by any associated cultural sanctioned practice. And the eating disturbance does not occur exclusively during the course of anorexia or bulimia. There's no evidence of a disturbance in the way in which one's body weight or shape is experienced. So they're not concerned about weight loss. That's not their focus. They're not trying to lose weight. But there's these feeding disturbances, which I'll get into. Um, so although many children go through phases of picky or selective eating, a person with ARFID does not consume enough calories to grow and develop properly. And in adults, they're not maintaining basic body functioning. In children, the results are stalled weight gain and vertical growth. And adolescents and children with ARFID are not concerned, like I said, about shape and weight. So like I said, it's not picky eating, it's fear of food, because maybe they had an aversive experience, maybe they choked, or they have difficulties with swallowing. They could have been NICU babies that that swallowing issue has been something that has consistently been a part of their life, and maybe they have they've been in treatment for feeding help. They've gone to OT or PT to do feeding therapy. So with ARFID, we're going to see a clinical presentation of 4 main types. So avoidant, and this is a teen and individual that is phobic, scared of food and eating due to an aversive experience with food. The person may have choked on a grape, vomited, or experienced difficulties with swallowing, and now they are anxious about the idea of eating due to fears that it could reoccur. For example, one of my younger teens I see had an aversive experience at Taco Bell. A chip got stuck in his throat and he actually started to choke, and the mom had to do the Heimlich on him, and he became extremely avoidant of eating anything that was what he called pointy food. So like chips, pretzels, because he was very scared he was going to have another aversive experience. So that's an example of avoidant. And aversive this is an individual who has a very limited diet. Oftentimes the diet's due to sensory features such as not liking the texture of food. This is common with people on the spectrum. So they don't like the texture, the feel of certain foods. So it's aversive to them. So they don't eat it. They cut that type of food out. Seeds. So some of my teens don't like seeded fruits. So your raspberries, your strawberries, the texture of that, something they just don't like. So they become aversive to that. Restrictive, an individual who does not eat enough, has a disinterest in food, and their body often doesn't show cues for hunger, and they often do not respond to hunger cues due to this disinterest in food and eating. So very small diet, there's only a couple foods that they eat. Maybe it's a lot of like the simple foods like, okay, peanut butter and jelly, chicken nuggets, or some more of the starchy foods, and they don't have hunger cues. So they continue to lose weight because they're not hungry. Food's not appealing to them. It's not the sensory experience that they enjoy. It's not pleasurable. So their body doesn't produce those cues for hunger because they haven't been eating regularly. And then mixed features, an individual who may duly present with both avoidance and restricting. So some signs of ARFID: dramatic weight loss. You're going to see these kids are not on their growth charts for height and weight. Constipation, abdominal pain, cold intolerance, low energy, lethargy, or sometimes even excessive energy. They might report consistent big gastro issues. So my stomach hurts, it feels full, I feel bloated, and oftentimes around meal times because it's anxiety, because they're scared of having that aversive experience with food. So their body might start to produce some of those signs of anxiety. There's dramatic restriction in types of amount or food eaten. Again, like these are my safe foods. These are the foods that I eat. They'll only eat certain textures of food. There's fears of choking or vomiting, lack of appetite or interest in food, limited range of preferred foods that becomes narrower over time, picky eating, and then that progressively worsens again to that restriction. Difficulties concentrating. Medically, we might see abnormal labs. They could be anemic, low thyroid and hormone levels, low potassium, low blood cell counts, and slow heart rate. So some assessment and screenings. There's a couple really good ones out there. I included 2 of them. These are great questionnaires. The EDE is a diagnostic interview that reflects current DSM-5 diagnostic criteria for eating disorders. It includes the 4 subscales. So it scales for anorexia, bulimia, binge eating disorder, and other specified eating disorder, OSFED. These categories do look for restraint, eating concern, shape concern, and weight concern. It's a great tool to get people to get a good idea of is this youth, is this teen engaging in compensatory behaviors? Are they restricting? What's a good picture of their beliefs about shape, weight, food? And it can be done. There's online versions of it where they can actually go online and do it. There's questionnaires that you can give out in your office just by printing off the PDF. The Eat 26, this is a screening tool that asks questions that fall into three general categories. These categories include distorted body image, body weight, bulimic behavior, and self-control. And this questionnaire is really great because it allows for a complete picture of symptoms and behaviors. These are great tools, again, to be used in doctor's offices, physician's office, your own personal office. And then you can ask a lot of follow-up questions related to them. Like, tell me more about the difficulties that you're experiencing around food. How is food presented in your home? Tell me more about how you feel about your body, the way that your body looks, the aesthetics of your body. These screening assessments have a lot of great questions that you can ask that teen. So jumping into treatment, it's really important that with eating disorders, we're using a team approach. We need the child to be seeing their physician. We need the child to be seeing a dietitian. We need the child to be seeing a therapist, and specifically a therapist that's versed in the treatment of eating disorders, because we have to really recognize that EDs are medical and psychological disorders, and we have to be able to address both the nutritional rehabilitation and the psychological rehabilitation. So that's why it's so important to have a team approach. We want to be engaged with their physicians, with their dietitians, referring them out if they're not seeing a dietitian or a physician, because the start of treatment for many of these teens, specifically teens who are experiencing anorexia, is we have to work on weight restoration. We cannot make progress on a cognitive and psychological, in the psychological areas, if we are in a state of malnutrition and starvation. So we have to focus and prioritize on weight restoration, restoring that child's weight, restoring that child's, getting them back into a healthy range. And that's best done in a team approach, and the family needs to be involved as well. So we want to normalize eating patterns and behavior. Really what I encourage, and dietitians encourage too, is the idea of a rule of three meals a day, 3 to 4 hours apart, and up to 3 snacks. I usually always suggest 3 snacks to start with, because we want to get their bodies to wake up to their hunger cues. We want to get their bodies to pay attention again to when they're hungry. And with binging too, like when we are actually eating on regular scheduled times, we're actually reducing the likelihood of falling into an episode of binge eating, because the body's not going through these periods of restraint, periods of restriction. And a lot of our hormones, like the blood glucose levels, are able to stabilize. So we want to normalize eating patterns and behavior. We want to help them get back to recognizing hunger and satiety. Again, that's very difficult for teens with anorexia because they're so turned off from their body, and they've gone through such a long time of not being hungry. So it's really hard to get them to recognize their hunger cues. Pay attention to, hey, that headache could be telling you that you're hungry. That little, turn in your stomach might be telling you that, hey, wake up, you haven't ate in a couple hours. So I oftentimes even encourage parents to, again, be on that schedule, put a timer on, and every 3 to 4 hours, that timer is going off, alerting them that it's time to eat again. And we want to correct the biological and psychological issues of malnutrition. We want to move the eating disorder out of the way. So here's Sarah, and Sarah was this lovely, joyful 16-year-old who played basketball and loved being with her friends. COVID hit, and now Sarah is focusing on, I could get in shape because if I lose some weight, maybe I'll be quicker on the basketball court. And slowly she starts to restrict, and this eating disorder starts to come in, and no longer are we seeing Sarah, but we're seeing Sarah who has an eating disorder, who is very focused on losing weight, is restricting, and won't give herself the permission to eat any and all foods. She's seeing herself through the lens. And when we correct the lens of the ED, and when we correct the biological issues of malnutrition, first, we're moving the eating disorder out of the way so that we can do the cognitive work, so we can do the value work of connecting her again to her values and what's really important to her. So we can do the, zooming out of let's look at the big picture of who you are, what you can do. But we can't do that if she's not getting the nutrition that she needs. We can't do that if she's underweight. We have to focus on the nutritional piece first. And then we want to build, restore a sense of self outside of the eating disorder. We want to build their support system, build their sense of self-efficacy, reconnect them to their values. And then we identify and address any comorbidities. We know anxiety is oftentimes a comorbidity, maybe substance abuse is, depression, OCD. We're going to address those things as well. So FBT is kind of the gold standard of care right now for teens with anorexia. And really why is FBT, or the Maudsley model, is designed to refeed the child in the home, because again, treatment is expensive. Going to inpatient res is so expensive. Some insurances won't cover it. I don't know of any that with a teen who has Medicaid that can find coverage at a res or inpatient center, which is really, really sad. Michigan too has no teen residential treatment centers for eating disorders. So FBT gives the parents a chance to focus on restoring that child's weight at home with the help of a team. So it's done with a dietitian, it's done with doctor, your PCP, and it's done with an FBT therapist who is going to conduct the FBT with the parents and child in the home. So FBT focuses on weight restoration and refeeding, and siblings provide a pivotal role of aiding and supporting their sister or their brother. The focus is on parental empowerment and equipping the family to feed and support their child in the home. And there's 3 phases of FBT. And FBT is done, it's a process, it's long, it's lengthy, it's strenuous. The course of treatment is usually a year because there's 3 phases of it. So phase 1 is weight restoration and gain. Parents have sole control of feeding, meals and snacks are all supervised. So when I say it's long, it's taxing, it really is, because that parent is sitting with that child at every meal. That parent is plating those meals. That parent is sitting with them during the snacks. That parent is in charge of making all of the meals. And it's tedious because there's fights at the table, arguing over the food. And sometimes that teen will sit there for 3 hours, which is exhausting for that parent. And that parent is sitting with that child during that time. Phase 2 is relinquishing some control back over to the teen. So as that teen has gotten weight restored, hey, we're going to let you choose your snack today. We're going to let you help with dinner prep today. We're going to let you meal plan on one of the meals that we have this week. And then phase 3 is short. It's focusing on normal adolescent development. How can the family help shape that child, help that child move out of the home if they're a high school senior and they're getting ready and prepared to go on to college. So phase 3 is focusing on normal developmental tasks and issues that occur during adolescence. So like I said, phase 1 makes up the bulk of therapy. Parents are in charge of weight restoration, assisting in decreasing binge, purge behaviors, and restrictive behaviors. Early weight gain is a good predictor of long-term outcomes. So a pound a week, which sounds so hard for that teen. It really does. They burst into tears when I say that, but a pound a week and 4 pounds by week 4 is a good indicator that that teen will recover. Because again, the best medicine is food. The best treatment at this point is weight restoration. So if we can get them gaining a pound a week, and we have gotten them up to 4 pounds by the end of month 1 of FBT, that's a great predictor. In FBT, an agnostic view of the cause of illness is taken, which is great. Nobody's to blame. The parents aren't to blame. The child's not to blame. This child didn't wake up and say, I want to have an eating disorder. So an agnostic view is taken, which really helps soften those feelings of guilt, shame. And there is a focus on externalizing the eating disorder. So we separate this child, this teen, from the illness. So Sarah is still there, just the eating disorder has gotten in the way. So when you're seeing that anger at the table, that's not Sarah, that's the eating disorder. When you're seeing her dig her heels and say, I'm not going to eat that, that's not Sarah, that's the eating disorder, because eating disorder doesn't want to lose control. So that can be super helpful for that parent. I'm not fighting with my child. I really am not. I'm fighting with this eating disorder. So, and parents are empowered to weight restore their child at home through refeeding. The therapist joins the family to act as a consultant and empower the parents. So like right now, because I'm virtual, I'm doing FBT over Zoom. So like last night, 6 o'clock, joining a family for our session I'm zoomed in, I'm watching them have their meal, providing coaching and support over that hour-long meal. So, but like I said, there is the dietitians involved, the PCPs involved. A lot of times my teens are going to their PCP for a weight check or dietitian weekly. Dietitian is helping with the meal plan because we want to make sure that we're increasing the meal plan, but we're doing it in a way where we're not putting them at the risk for refeeding syndrome. The focus is on a gradual return of control to the teen for phase 2. When we move to phase 2, when we move to phase 2, I don't know what this is. When we move to phase 2, we are giving the child control of eating slowly. And a good indicator of moving to phase 2 of FBT is we have weight restore. That child has had to get back on their growth chart. So we use growth charts with FBT. They're back on their growth chart, their weight restored. And now we're giving them control. Hey, you can choose a snack. You can choose what we're going to have. There's more flexibility built into the meals and food choices. And the teen starts to eat outside of the home with peers. Like they get to go to Chick-fil-A. They get to go to sleepovers. They're having their snacks independently without mom or dad sitting right there with them. Phase 3, this is where we address adolescent issues, normal adolescent development. We model problem solving with the family and the child. We're going over coping skills. And again, we address any co-occurring issues. So the wrap-up phase, this is where we're, instilling their independence and encouraging them to use healthy coping, maybe teaching them some coping mechanisms, going over some problem solving. Yeah, that sleepover is coming up. And there are going to be foods there that have been difficult for you, like cake or ice cream or pizza. So what can we do? How can we prepare for that? So having some of those discussions. You're going away to college and you know that it's going to be difficult because it's a big change and you've never left the home. So how can we create some support for you when you go away to school? So some other areas of treatment really quickly, because I know we're almost out of time. I really love acceptance commitment work, acceptance commitment therapy, which really focuses on values work, because we want to separate what is the eating disorder value, what do you value? And we want to talk a lot about hey, let's live in step with your values, have them go through a value sort activity and really do some contrasting. So if you value adventure, if you value social connection, your peer relationships, how is this eating disorder making it difficult for you to engage with your friends, to pursue adventure and really create that dissonance? And we'd also do some cognitive diffusion. So you aren't your thoughts. We don't want to fuse with our thoughts. We want to recognize ourselves. We want to recognize that our thoughts are transient. They come, they go. We can create separation. We can notice I'm having the thought that I feel uncomfortable, or I'm having the thought that my body looks different instead of I am this or that with our thoughts. So CBT, we can focus on understanding the person's eating problem, helping him or her to modify, stabilize their pattern of eating. There's an emphasis on education and addressing the concerns about weight. So in CBT, we can do some psychoed. The therapist and team focus on enhancing the ability to deal with day-to-day stressors, their moods. We address dietary restraint. We focus on understanding and identifying cognitive distortions. Maybe they're emotional reasoning, maybe they're overgeneralizing, or they're getting stuck in all or nothing thinking. We want to create some flexibility. We might work on some core beliefs. Maybe they have a core belief of inadequacy, and their shape and weight is a way for them to compensate for that belief that I'm inadequate, I'm defective in some way. So we want to create and reframe their belief system, and then doing some body acceptance work, body image work as well. And I always say that kind of comes last because that's harder. And if they're, again, undernourished, malnourished, it's really difficult to do that body acceptance work. DBT, so we can work on distress tolerance skills, urge surfing for binge eating, as long as it's not been because of restraint, work on core mindfulness skills, taking a non-judgmental stance, tip skills to use when you're feeling emotionally dysregulated. So DBT has a lot of great stuff. And then ERP, this is really helpful for teens who have restricted certain food groups. So we want to introduce a fear food through exposure response prevention. So we're going to tackle cookies this week, and we can make a hierarchy of fear foods. Maybe at the top is a piece of cake and at the bottom is cookies. So we want to focus on exposure and getting them to eat the foods, specifically with our food. It looks like there's chat at the bottom. So maybe I'm out of time. So Sorry, I know that was a lot.
Sorry, Kelly. This has been so good and such great information, but unfortunately,
Yes,
we have to end so the
definitely.
other sessions can start.
I'm
So,
so sorry. Yes.
no, this has been good, and I think we're going to have opportunities to get your contact information to our participants. So,
Absolutely. Yeah.
thank you
Thank you.
so much.
Yes, no problem. Thank you, everybody.
All right, take care.
Okay, bye-bye.
Bye.